Hello and welcome to this ENT Expert Opinion podcast series. My name's Niall Jefferson. Today I'm in Hawaii with Associate Professor Bradford Woodworth. Dr. Woodworth is an Associate Professor of Surgery at the University of Alabama School of Medicine and holds the James J. Hicks Endowed Chair of Otolaryngology. He completed his fellowship training in rhinology and sinus surgery at the University of Pennsylvania and currently is an NIH-funded researcher investigating therapeutic interventions that enhance mucociliary clearance in both cystic fibrosis and non-cystic fibrosis chronic rhinosinusitis. He's published and presented extensively, nationally and internationally, and it's a great pleasure to talk with him today. Good morning.
Good morning.
All right, so today we're going to be talking about cystic fibrosis and chronic rhinosinusitis. To begin with, in general terms, what is cystic fibrosis?
Cystic fibrosis is a autosomal recessive disease. Predominantly affects Caucasians. Is actually thought to be the most common lethally inherited disease in Caucasians. It affects about 1 in 2,000, 1 in 7,000 live births. It's about 70,000 adults and children worldwide. Cystic fibrosis presents with problems with multiple organ systems, particularly the lungs, sinuses, pancreas, GI tract, and a lot of people have azoospermia or infertility secondary to the disease. The underlying defect is a defect in the protein cystic fibrosis transmembrane conductance regulator from genetic mutations. So cystic fibrosis creates hyperviscous mucus and dehydrated mucus in these organ systems, and it's secondary to a defect in the cystic fibrosis transmembrane conductance regulator. This gene that causes cystic fibrosis was identified in 1989. Some of you know Francis Collins, who heads the NIH, who's one of the team members who identified it. And since that time, there's been a great growth of understanding with how cystic fibrosis develops. Essentially, this is a apical chloride channel, the predominant apical chloride channel in these organ systems, including the pancreas as well as the lungs and sinuses. And it results in a lack of transport or decreased transport of chloride across the apical surface of the respiratory epithelium. And what that ends up is it results in a hyperviscous mucus, dehydrated mucus, and airway surface liquid, and subsequently secondary superinfection and chronic problems with the lungs, which is the major cause of morbidity and mortality, as well as the sinuses. There are several classes of mutations. Class 1 mutation involves difficulty with transcribing the gene product. And these patients manifest as such as the G542X mutation. These patients have no protein, which actually gets translated, and no protein on the cell surface, and they typically harbor a widespread outcut or widespread morbidity from cystic fibrosis. The class 2 mutation is the most common mutation. It's called the F508del, or some people know it as the delta F508 cystic fibrosis mutation or CFTR mutation, and this results in a transcribed mRNA and translated protein, but that protein gets hung up in the endoplasmic reticulum before it gets transported to the surface. It gets recognized as foreign because it's misfolded, and then gets degraded in the proteasome. The third class of mutations results in a normal amount of protein on the cell surface, and this is a common mutation here is the G551D mutation, which affects about 4% of the CF patients in the United States. This mutation has normal levels of surface protein, as I mentioned, but the channel actually doesn't open normally, and so there's a lack of chloride transport. The other minor mutations, class 4 through class 6, the class 4 mutation is a cell surface. The CFTR is on the cell surface, but has a partial functionality, so these patients typically have less severe disease. Class 5 mutation is one where there's a decreased number of transcripts, so there's a decreased number of protein on the cell surface. And then the class 6 mutation, which results in accelerated turnover or an unstable protein on the cell surface. Class 4 through 6 are generally milder mutations and they have milder disease.
It's clearly quite a complex disease with a broad spectrum depending on the mutations involved. How does it then play a role in CRS?
So CF plays a role in CRS because CRS is nearly universal in cystic fibrosis patients. There are several forms, as I mentioned. There's a non-classical CF, which may have a manifestation of one organ system, such as the pancreas, and less severe sinus disease. These people typically harbor the minor mutations. And even some people have what's called CFTR-related disease, where they have maybe one F508del mutation, and they have a higher incidence of chronic sinusitis when compared to the normal population. So it shows that certainly lack of functionality in the CFTR channel can result in chronic sinusitis. With people with severe CF, they typically have widespread pain, sinus, and mucosal disease, require multiple surgeries, have relatively refractory nasal polyposis, especially in early age. And these patients have significant, only about 20% of the patients actually have significant symptoms, but up to 100% actually have a severe disease or at least mucosal abnormalities on CT scan.
So then, how do these patients present, usually at what age?
So in a young age, a person with cystic fibrosis can actually be diagnosed with CF because they have nasal polyps. Any child under the age of 5 with nasal polyposis should be considered to have CF until proven otherwise. These patients typically aren't all that symptomatic except for some nasal obstruction, maybe some facial pressure, but they may get more symptomatic as they age. A lot of the early surgeries or surgical interventions that people do are nasal polypectomies with minimal sinus surgery, and these tend to help the nasal disordered breathing that these patients have. As an adult, some minor mutations may present with recurrent sinus infections or recurrent lower respiratory infections and be diagnosed later in life because they may not have as severe disease as other CF patients.
Most, cases then of cystic fibrosis would be in the younger age group when they first present. What do you want to know from their history when they come to you?
So from a history standpoint, if they're a child, they have nasal polyposis. If they've had a complication, if they've had a history of meconium ileus when they were born, they have pancreatic exofunction. Most of the time, these patients are going to be diagnosed by their pulmonary physicians or pediatricians. And also with the advent of genetic screening, a lot of these kids are diagnosed as newborns. From a standpoint of history examination, when I have an adult patient or a patient who has known CF, what I want to know about their sinuses are are they having symptoms? That's the biggest thing. If they have, only about 20% of CF patients have self-reported symptoms, despite many of these patients having multiple sinuses filled with mucopurulence. The people who have symptoms, I want to try and treat more aggressively than the ones that don't have symptoms. The main things are facial pressure, pain, loss of sense of smell, postnasal drip, any foul odor, and there's, of course, headache and nasal obstruction.
So you've taken your history. What about your physical examination?
So physical examination is going to be a standard routine head and neck examination, but really the critical portion is the nasal endoscopy. When I see these patients, if you have a peds patient, these are going to be much more difficult to do an examination of the intranasal cavity. However, for an adult, these patients have had multiple endoscopies throughout their life and may be more used to the procedure. What you want to see is extent of former surgery. You want to look for any abnormalities, perforated unset process if they haven't had surgery in the past, polyposis, extent of nasal or sinus purulence. You want to look for any synechia from previous surgery or blocked or closed ostia. In particular, the maxillary sinus is a very problem area because there's very little space between the inferior turbinate and the medial orbital wall.
Is there such a thing as a routine investigation in these people?
Routine investigations depends on why the patient is presenting. If the patient is presenting for a routine check of their sinuses because the pulmonologist just wants to check on their sinus health, it's going to be a different scenario than a patient who's grossly symptomatic, or even a younger patient who hasn't been diagnosed yet, or an older patient who you might suspect of having an atypical CF presentation. The first thing is in a child is to, once again, you check that endoscopy, but you also want to know what their FEV1 is. In any CF patient, the pulmonary function test, which follow lung function. Lung function is determined by the forced expiratory volume in 1 second. This has been shown to be a reliable indicator of pulmonary exacerbations. And quite often these patients have sinonasal exacerbations at the same time as pulmonary exacerbations. Other things to think about for a patient with recurrent respiratory and lower infections who has not been diagnosed with CF in the past is to think about a sweat chloride exam or sweat chloride test. The sweat chloride test is considered abnormal at greater than 60 millimoles per liter, but some atypical CF presentations will present with sometimes even less than 40 millimolar. but between 40 and 60 is a common presentation in that scenario with minor mutations. So that is very helpful. Other things to consider, genetic screening for a patient. You might consider to have CF. Say they have recurrent Pseudomonas sinus infections and recurrent respiratory infections, and you'd like to check that function as well. And of course, if the patient hasn't had a CT scan in some time, you'd like to treat them aggressively from a medical standpoint. If they have known CF, that's certainly fine, but some of these patients, since they may not undergo surgery and they may be asymptomatic, should at least get a screening CT once every several years to make sure they don't have opacified and expanding sinuses such as a mucopyseal or mucoceles that may result quite frequently in this disease process.
We've talked about a range of investigations. You've got a patient with cystic fibrosis. They've come to you for management. They are symptomatic. Where does that start?
So the first thing I'd like to know is the length of their symptoms. How long have they been symptomatic? Is it associated with a pulmonary exacerbation? Does it get better with IV antibiotics when they get admitted for a pulmonary exacerbation? What kind of treatments do they do normally for their sinuses? Are they patients who routinely irrigate with saline? Do they use any other topicals? Do they get any other administration for the sinus disease? Do they take antihistamines? They have a history of allergy, because CF patients certainly can have a history of allergy as well, which can compound the problem. The standard treatment of CF patient may vary, and these issues haven't been worked out because there's not a lot of evidence in terms of medical treatment for these patients. There's no randomized clinical trials except for Dornase alpha, which is typically used in the postoperative period. The standard treatment should be a more aggressive medical management, such as culture-directed antibiotics for 3 weeks. The use of sinus irrigations, particularly isotonic, but sometimes hypertonic saline, which is more physiologic in a CF patient, and can help hydrate the airway surface liquid. Other things are a round of steroids if the patient is not diabetic. Can also help with some polyposis, although these polyps are more refractory than eosinophilic polyposis, but it still is helpful. And then other things like topical steroid, such as a Flonase or other steroid irrigation, which I prefer for better penetration. These patients then can be followed with a CT scan if they have, when they return to clinic. We check on their symptoms, check on their endoscopy, and check the CT scan, go through the CT scan with the patient, and determine whether surgical intervention might be able to help improve their symptoms, and whether they're going to be compliant with rinses after the procedure to make sure that things stay clean postoperatively, and make sure the patient is compliant with their sinus and nasal regimen. Let's
talk about surgery. Is surgery always indicated? And when you do perform surgery, do you advocate for routine megaantrostomies, primary lothrops, more extensive sinus surgery at the first sitting?
This is a very controversial topic, Niall. The pediatric otolaryngology role of sinus surgery in these patients has typically been during pulmonary flare-ups for inpatient hospital admissions. Many of these patients have had multiple procedures, and they're usually very small osteomatal complex type procedures to clean the sinuses. The difficulty with this is that these sinuses are like abscess cavities. They don't have intact functional mucus clearance, and these sinuses typically fill right back up with mucopurulence. Multiple studies have shown, particularly by McMurphy in the HARA, they did a study showing that 6-month postoperative CT scans basically look the same in these patients after sinus surgery. And so affecting any real change in these patients, I think, is difficult overall. And while the patient may have some benefit symptomatically, I think the more important thing here is to determine methods to increase the amount of mucus clearance that the patient has. The difficulty with determining candidates for the procedure are the conflicting results in the literature in terms of how sinus disease impacts pulmonary outcomes. From a pulmonary outcome standpoint, several retrospective studies have shown a benefit with sinus surgery. Others have shown no benefit with pulmonary outcomes. So in the end, it's going to be up to the individual surgeon about who they're going to bring to the operating room. My personal preference is to make sure that the patient actually has symptoms if we're going to operate on them. So I do not operate on asymptomatic patients unless they have an impending complication. From a symptomatic standpoint, my preference is to do a full house sinus surgery. I do give the patient option of modified endoscopic medial maxillectomies, also sometimes called maxillary megaantrostomies, as you mentioned. The purpose of this procedure is because the maxillary sinus is the largest sinus, holds the most pus, and is the most common recurrent problem area for these patients. If you bring down the wall of the sinus, what that does is marsupialize the maxillary sinus into the nasal cavity. It makes it much easier for cleaning, for clearing mucus from a standpoint of sinus irrigations. The whole purpose is to prevent, hopefully, future general anesthesia as these patients have declining pulmonary function over the years. If they have symptomatic flare-ups in the future, it would be nice to be able to clean them under some sedation or in the clinic setting. When I present the modified Lothrop's or draft-free procedures are quite difficult situations in CF patients, as the patients who do have frontal sinuses, they're often very slender. There's a big block of bone there, and a draft-free procedure doesn't give the classic look that you'd want because the sinuses are very separate, and you often have to do extensive drilling even above the nasofrontal beak. And so my preference from a frontal sinus standpoint is to just do a frontal recess dissection and just manage them symptomatically in the clinic with either Van Allia cannula or some smaller suction when they become symptomatic. Other strategies are to perform or administer steroids in the Meigen's, M-Y-G-I-N-D-S position to allow reduction of inflammation in the frontal recess if they're developing headaches in this region. The best patients for, or best candidates for surgery are those that don't have frontal sinus or have aplastic frontal sinuses, smaller ethmoid cavities where there's less disease that can occur in that region, and then maxillary sinuses that are hypoplastic and you bring down the wall. Essentially, then everything can be marsupialized into the nose, and it's very easy for cleaning and for chronic maintenance with saline irrigations and other topical medications.
So let's talk about what are the topical treatments, particularly in the postoperative period.
So what I prefer is saline irrigations as a base. Isotonic saline is much more easy to handle from a standpoint of tolerance. However, if they can use hypertonic saline, I think it's very useful from a hydrating airway surface liquid standpoint. As the studies have shown that nebulized hypertonic saline in the lungs has been beneficial. However, I don't want CF patients to fear doing their irrigations, so I'd rather them do isotonic rather than hypertonic if they don't tolerate the hypertonic. The second thing would be talk about topical antimicrobials. There are no randomized controlled clinical trials looking at this subject. However, there have been some postoperative prospective trials looking at tobramycin as beneficial in CF sinusitis. My preference is to try and control infection over time, and so most patients have Pseudomonas that's sensitive to tobramycin, and I do use tobramycin specifically in the postoperative period and sometimes permanently in their irrigations as over time to keep infection under control. Mupirocin is also another additive which is beneficial for Staph aureus, and so I also frequently add this for methicillin-resistant staph as well. The other thing to talk about is steroid rinses. There's several steroids on the market that have low absorption, particularly mometasone, which is very useful from a standpoint of inflammation. Although the neutrophilic inflammation in cystic fibrosis is not as sensitive, we still know that prednisone and other steroids help with the inflammation and the symptoms of the disease. So using that is helpful, especially for people with frontal sinuses, who can use the Meigen's position in the frontal recess to control the inflammation and help with pressure. The best evidence we have for postoperative treatment in this patient population is actually Dornius alpha or pulmozyme. Nasonebulized pulmozyme has been shown in 2 small randomized controlled clinical trials to improve postoperative sinus outcomes in this patient population. The problem with the pulmozyme is that it's quite expensive. Patients can have some nasal bleeding from the drug, but I think with people who are actually on pulmozyme already for their lungs, switching them from an oral inhaled nebulizer back to a face mask with inhaling through the nose is also a benefit in this postoperative period. The pulmozyme actually thins the mucus by getting rid of DNA, which is a breakdown product of the neutrophils which form in the mucus, and it helps thin the mucus.
You've mentioned irrigations, intranasal steroids and so on. What's the long-term outlook for these patients?
So long-term outlook, most patients get numerous sinus surgeries over their lifetime. In my hands, what our attempt to do is to make it so that these patients return to clinic at the same time as their pulmonary appointment every 3 months. That way we can clean them in the clinic and keep their sinuses clean. Sometimes we don't have to clean them because they're doing a good job cleaning their sinuses themselves. And we follow them symptomatically over the long term. This is a genetic disease that's not going to go away. Their mucociliary clearance is completely non-functional until the day we can actually reverse the genetic defect or problem with the CFTR channel protein. We won't have the ability to quote-unquote cure these patients. Many of the adult patients that we see from a CRS standpoint have had Pseudomonas or mucoid Pseudomonas with multiple resistances, as well as methicillin-resistant staph in about 80% of patients at this point. These patients have had multiple rounds of IV antibiotics. They've had multiple antibiotic drug resistance to their bacteria. And so it's more, instead of attempting to completely eliminate the bacteria, essentially what we're doing is trying to keep the infection under control, keep the mucus moving, and keep the patient less symptomatic. The long-term outlook from a medical standpoint is really just targeted strategies, ultimately to affect the CFTR channel protein.
To that end, is there a future goal as far as is cure an option?
So there are a number of therapeutic strategies ongoing right now in the CF world. The first therapeutic strategy is identifying small molecular weight compounds and identifying ways to interact with the CFTR protein. And these will be called CFTR modulators because they affect the function of the protein. A couple of different strategies exist. The first is there was recent FDA approval for a compound called originally called VX770. Now the generic name is called ivacaftor, and the trade name is called Kalydeco. And Kalydeco essentially is for patients with the G551D mutation. As I mentioned, a class 3 mutation. If you have one copy of this mutation, the purpose of this oral drug is to improve channel function. So this protein does not open properly, and this drug actually reverses those effects, which was recently published in the New England Journal of Medicine. So the patients with the G551D mutation who are going to receive the medication in the future at the younger age before lung damage ensues should have a much better overall quality of life and improved mucus clearance, and hopefully not suffer a lot of the effects that patients with cystic fibrosis have to undergo daily. Other strategies include, in particularly the holy grail of CFTR modulators, is affecting the F508del CFTR mutation. As mentioned earlier, this protein is misfolded in the endoplasmic reticulum, and the purpose of these modulators are to properly fold the protein and get a certain amount to the cell membrane or the plasma membrane so that that channel protein can enable ion transport. There is currently ongoing clinical trials looking at a combination of ivacaftor or Kalydeco with another compound called VX809, which will allow a certain amount of the F508del CFTR to get to the plasma membrane. We don't have the results this yet, but we should have updated results at the North American Cystic Fibrosis Conference this year.
One thing that I like to finish with is a thing called the final word. So it's an opportunity for you to either touch on something that we've covered that warrants highlighting, or maybe mention something that we haven't talked about that is important within the discussion of the topic. So I'll hand it over to you for the final word.
So I think as ENTs, CF disease has been relatively underserved. Part of the reason for this is the chronic nature of the disease and difficulty with long-term follow-up and recurring issues with the sinuses. I think as ENTs we should attempt to develop a better treatment paradigm to control sinus symptoms better, to help with overall sinus health, have better collaboration with our pulmonologists, as a newer treatment paradigm to help these patients. Currently, right now, our goal is to maximize our efforts as a cystic fibrosis team, work together in a pulmonologist for both inpatient admissions and outpatient clinical setting to affect sinus health through both surgical and medical means. From a standpoint of medical treatment, I think in the future, with the ongoing research that's involved with CF, we hope that modulating the CFTR protein will become the norm, and many of these patients will exhibit an increasing lifespan with less morbidity over time. Current median lifespan for a patient with cystic fibrosis patients is 36.9 years of age, but many patients have to get lung transplants and the like, and our hope is that cystic fibrosis patients in the future will have a long, fulfilled life that will have less sinus disease, less pulmonary problems, and part of the ways that we can do that is to have more research into both chronic sinusitis outcomes as well as pulmonary outcomes. And these newer strategies that I talked about earlier will be an excellent method for future interventions.
Look, thanks very much for joining me. This has been another ENT Expert Opinion podcast. You can find more podcasts at iTunes or at the website entexpertopinion.com. Aloha.